Okay, Sinead Dufour, I am always so excited to have these conversations with you because we've had some good ones on this podcast before. And I hope you're told this as much as you deserve it, Sinead. Like you are just such a inspiration, I think, to so many physios. I don't know how you do it all, but you, in so many different areas, you are such an advocate for our profession, but also just for better care in so many different ways. And I've sure have appreciated you on a personal note, like just how many things you help me with. So thank you for so many
Thank
things
you
that
for
you
having
do.
me again, Mel. I always love our conversations. I think your podcast is so important to really kind of like push out to all our other sort of colleagues, honestly, but also like healthcare consumers, clients, patients, whatever you want to call it, to really just kind of awareness raising, I think, in this space to kind of lift us all up. So, no, it's a delight to chat with you again.
Absolutely. Can you just, for the listeners, go into a little bit about who you are, Sinead, before we get into this topic?
Of course, happy to. So, yeah, so I'm Sinead Dufour. I'm really what I would call an academic clinician. So I spend some of my time sort of in the academic world, doing research, teaching at McMaster University. I teach medical students. I teach physiotherapy students. I've historically taught midwifery and nursing students as well. So that's sort of my academic side, but also I've been a physio for over 20 years. The last, I don't know, 10 to 15 years, really focusing in sort of perinatal care and pelvic health. I'm the co-founder of a company called The Womb, The World of My Baby. So really, I mean, this is a whole family of perinatal care centers in Ontario and Canada. And that really is where so much of my passion is. Like, yes, in pelvic health, but really kind of this perinatal sort of space. So I've also spent over a decade working very closely with the Society of Obstetricians and Gynecologists of Canada, sitting on a number of their committees, leading a number of their clinical practice guidelines. And very much like anything that sort of helps to advocate for this space, I kind of try to be there. So yeah, that's a little bit about me.
And I think this is why I like talking to you so much because this is how my brain works too, is I think our healthcare system and a lot of these concepts that we talk about, it's like people get stuck in the weeds or like the details.
Mm,
And I love the big picture and like connecting dots. And I think we have a hard time connecting dots sometimes in healthcare.
mhm.
And so it's almost like we're looking too close instead of taking a zoom out. And so we're going to zoom out a little bit on birth today and
Mhm.
preparing for birth. And to set the stage, we see a lot of clients that are pregnant. They come in to see someone like a pelvic floor physio. And whenever they come in, I'll ask, what brings you in? And the number of times they say, I don't really know. I mean, my friend told me to come, but they can't really pinpoint why they're there. Or they'll say kind of if I could just talk candidly, I'm terrified of tearing and I understand this is related to my pelvic floor, so I'm here for you to help me, right? And
Mhm.
personally, I quite often start with the pelvic floor because I'm trying to meet them where they're at. Like I don't want to start talking about the nervous system or the brain because I don't want to lose them, right? And they're thinking about the pelvic floor, so I talk about the pelvic floor at the beginning.
Mhm.
But then quickly, I want to get to the idea that the pelvic floor, I always say, is a follower. There's other things that are leading it, and help them understand that the way your brain thinks or the way your brain perceives this, or certain things you do with your body will have a direct positive influence on your pelvic floor to help let a baby out. And so there's a lot of education there.
Mhm.
And I think that you know they are just so into the pelvic floor, sometimes they're having a hard time that like, what do you mean my brain's related to this, right? And
Mhm.
they're a lot of times their goal is that I want to have what they would consider a physiological birth. Like I want my birth to come spontaneously. I want it to, and this is some people's goals. I'm not speaking for everyone, but for a
Mhm.
lot of them that are coming in, this would be their goal. I want it to progress without or with little medical intervention. And I'd like to have a vaginal birth, right? And
Mhm.
so um, I think a lot of people have that goal.
Mhm.
but they're coming to see us to help them achieve that goal. And so
Hmm.
let's just talk a little bit today about, you know, some of the things that are going on in the current landscape. Like, are people having those physiological births very often? And how are we helping women do this? And then just to set the stage, we're going to eventually talk about some of the research that you've done around preparing the brain for having, for having I don't want to say a successful birth, but like the birth that they're wanting to have, right?
Yeah.
Okay, so that's a lot of me yakking there. But what else do you
Yeah.
have to add to that first? Just around like, the goals that people have, and are those being achieved? Are people happy with the births they're having?
Yeah. So honestly, Mel, I feel like your experience, of course, is very similar to mine, and we've chatted about this many times offline, but absolutely. So first off, I would say, one of the things that's actually really nice as a pelvic health PT is that people are starting to seek out our care, what I would say on the front end, rather than after their birth, and kind of really more truly in that rehabilitative light, like they're kind of rehabilitating, they're recovering from an injury that happened, and it's sort of more reactive, which is really important, and it's a great role that we play. But I mean, an ounce of prevention is worth a pound of cure. So the fact that people are coming to us on the front end because they're hearing either, exactly to your point, like from their friends, from their sort of pregnancy mom groups or whatever it is, that, hey, there's this group of practitioners called pelvic health physiotherapists that, a lot of people don't even know that we exist. But I mean, they can kind of help you navigate through this kind of space to have a better pregnancy and a better birth and a better recovery. So, yes, I would agree. Like, we have such a profound role in that space. And part of the reason why is to answer one of your other questions. Unfortunately, there is sort of discordance between, from a Canadian perspective. So, Mel and I, of course, are in Canada on opposite ends of the country, but we're here in the same country. And from a Canadian perspective, and I know this is also the case in other kind of like westernized countries, but really, we have sort of a slew of international practice guidelines that all sort of align. So even if we think of like the Society of Obstetricians and Gynecologists of Canada, that group that I've done quite a bit of work with, and then we even compare their guidelines with ACOG, which is the American equivalent. Actually, the guidelines are pretty much the same for birth, which makes sense because they're drawing on the same international literature, which essentially advocates for physiologic birth. Essentially the consensus is that following these things are better for mom and better for baby. The trouble is that these guidelines are not enacted very well. They're not implemented. So we have this discordance between what we know is best for mom and baby, what generally mom actually wants is in line with these established guidelines. But we have this kind of whole infrastructure and almost like this machine that's running, which is sort of like the healthcare system that operates in a different way according to some different factors that kind of drive it. Unfortunately, we have, understaffed nursing wards. We don't have enough beds. We have these other constraints that end up driving medical decisions. And so it's what I call like the social construction of birth care. Right. And that is a reality, right? And it's not to point fingers and blame anyone in particular. It's just to say, like, that is part of the reality of why there's this discordance. And so at the end of the day, it really does mean that, birthing people almost have to sort of think of themselves a little bit like a health consumer rather than a patient, I would say, just to really be empowered and really to kind of try to get, as up on the knowledge as they can so they can advocate for themselves. And I mean, ideally, if they have, the money to afford it and whatnot, to have a doula with them. Right. So that is one recommendation that is consistent across the board. Level 1A evidence that if you have a doula with you to support you through your birth, there is positive translation on almost every single outcome by a significant margin. And so it's really interesting. I mean, you said it at the beginning there, Mel, people will seek our care and say, hey, like, I'm a little bit afraid of this birth process. I'm afraid of tearing, I heard if I booked an appointment with you, you could help me prevent tearing. And I think in a lot of the cases, these individuals are really expecting us to kind of do some magical sort of like
Mhm.
stretch technique on their pelvic floor and give them this like perfect perineal massage protocol.
Mhm.
And that'll be the panacea. And it's to acknowledge, yes, of course, like having an understanding of the structure of the pelvic floor and the role it plays is really important. It's one part of it. But compared to a lot of the other cognitive and physiological drivers and social context, it's such a small piece of the pie. And really, I try to, as quickly as possible, get to the point of if you really don't want to tear your pelvic floor in your birth, get a doula,
Mhm.
right? And of course, it takes a bit of time to kind of get
Mhm.
there. But yes, we definitely have a little bit of a bridging function that we're trying to do here between this disconnect between practice-based care and evidence-based care, and frankly, preference-based care, which is like the preferences of the person receiving the care, which is actually one of the three pillars of evidence-based practice. And in obstetrics, that preference piece really kind of seems to get lost more so than in other domains. So this is too where our role as PTs, our role of an advocate, it is one of our established roles within our professional competencies, this advocacy role. And I would argue in this space, it's a really important, prominent role because of some of the landscape of what exists. So I'll just kind of say that to kind of out the gate, and then I suspect you'll have some follow-up questions too.
Well, yeah, and I think that like if I was to capture some, sorry if you can hear like banging in the background, this was unanticipated here, but um I think like if I was to capture some of the thoughts around some of these people coming in pregnancy, it's oh, like I don't want to plan because I want to be flexible. And at the end of the day,
Mhm,
I've never done this, so I trust the providers that are there. Like
mhm,
I picked this group of midwives for a reason, or I've got these great doctors, and like this hospital knows what they're doing because they do it all the time. So I think there's almost this like I know nothing,
mhm,
they know everything, and I don't want to seem difficult by like kind of planning too much. And I think that's what we're going to get into a little bit is that like in a
mhm,
lot of ways you can plan to work with your body or plan to work with what's coming. But I do find that especially with all of the information on social media that's like you need to do this and you need to do this and you need to do this, it's almost like they're trying to memorize a recipe, of some of the things they need to do. Like, okay, when do I do this? And when do I do this? And when do I do this? But maybe I don't even want to think about that. And I'll just trust that they'll tell me. Like, because I think it depends on the personality of that person coming in. And I
mhm,
think that, like you're talking about, is we have such a role in helping them understand their body. Like, I don't think we learn enough. Like most of these women are really not learning about their anatomy. Like just how does their uterus relate to their vagina, which relates to their pelvis and their pelvic floor? Like what does that even look like? How does that
mhm,
behave? What does pain do to that area? Because I think it's not about memorizing a recipe, but more like, oh, in the event that I feel this, these are things that I can do. That's not what I think anyone learns in
mhm,
traditional education, like the childbirth
mhm,
classes or anything like that. Would you
mhm.
not say then that's part of the problem in the quote unquote preparation for having a baby? I don't know that we're learning enough about how our body works and
Mhm.
how it works with pain and that knowing your body can help you react in the moment or respond in the moment. So I
Mhm.
guess what I'm trying to get at is the current way we prepare women is a little confusing.
Yeah, I would agree with you 100%, Mel. And I would also say you're quite right. What the focus on is in sort of like, again, from a Canadian context, our publicly funded sort of birth prep or prenatal education that are offered through our publicly funded systems, typically within the hospital context, are very, very focused on sort of like the what and kind of procedures and like what are the stages of labor. And it's very focused on all these things that are external to us, all these things that are kind of going to be done to us. And so you can appreciate that, not a surprising strategy that women have as a coping mechanism is because they're so overwhelmed, they almost just want to turn that off and say, you know what, I'm actually just going to sort of trust my practitioner
Mhm.
because it's actually so overwhelming and it really isn't empowering. And so you're quite right. If we can kind of shift things to say, well, you're right. I mean, there is a whole complex array of things that go on to bring a human being earthside. And there are so many facets to that that we don't understand. And I don't think we're meant to understand. And that is okay. There's a mystery there, which is okay, right? But if we can kind of be good with that and say, but let's kind of control the controllables. And we can at least understand how our pelvis works. We can understand how our pelvic floor works. We can at least understand, that when we've been sort of living in a particular way, it changes our brain structure. So when we've been like a hypervigilant individual and kind of looking at like screens constantly, that actually changes your brain structure. That actually makes your amygdala and your threat center a lot bigger. Whereas if you've engaged in an operating rhythm in your life where you actually do mindfulness or spend a lot of time in prayer, that actually changes your brain structure to make your amygdala smaller. So you're less likely to interpret every single thing as threatening, right? So there's a number of things within our context that we can have a lot of control over, not just for birth, but for anything that's unexpected, that is going to be difficult, that has multiple systems being pushed to the edge, like any type of event, even if you think you're going to run a marathon for the first time or whatever it is, right? So there's lots of things we can do to train and prepare ourselves. And generally, yeah, we have kind of got this bit, you know, a little bit wrong when it comes to really optimally preparing these mamas. And so in ways, I mean, we now see sort of a little bit of alarm being raised by our colleagues in urogynecology saying we have these pelvic floor dysfunctions that are at epidemic rates. We have an aging population. We have crazy numbers of prolapse and really, really severe urinary incontinence. And as a group, as the people who do exquisite surgery in these areas, which we need in cases, and these are amazing allies of ours, they cannot keep up. And it's a matter of saying, well, what are we looking at upstream so we don't have this problem in the first place, right?
That and in combination with like, so you're talking about kind of like some of the pelvic floor results, but also too, like we see C-sections on the rise. We see
Mhm.
the goal of this physiological birth is not being met by a lot of people. And so and some
Mhm.
of the, the number of people that come up with, whoa, that's not what I was hoping for, or that's not what I expected. So I guess what I'm trying to do so far is like set the stage that like we're noticing that, there's some discrepancy in what maybe people are looking for and what they're getting, or in kind of like helping that natural process of birth, which I'm sure led you to do some of the research that you've done. So I think I'm trying to kind of say
Mhm.
like there's a reason you did some of this research. So can you talk a little
Mhm.
bit about like, you've taken all this information, and then tell us a little bit about some of the research you've done to kind of say like, listen, we need to think about this a little different.
Yeah, absolutely, Mel. So, yeah, what I would say is first, being so involved with the Society of Obstetricians and Gynecologists of Canada and being aware firsthand, like these are actually the recommendations from the guidelines, and kind of almost being shocked in my practice to see like these do not line up at all. Like, this is kind of crazy, right? And then, within the womb, the world of my baby, my practice, I'm so blessed to have worked for over a decade in this kind of care model that really does enact the guidelines. But of course, we are not at the intrapartum birth place. The midwives who work with us are, the doulas who work with us are, but everyone else is sort of seeing people either kind of before or after. And really, all of our team is kind of trying to sort of enact what the guidelines saying and sort of seeing that, yeah, this translates consistently to more physiologic birth, better birth, less trauma, like all of the things that corroborate with the research literature, right? And so that got me to kind of thinking even about pain neuroscience education, because of course, as physiotherapists, this has become a really important sort of psychologically informed care technique that we have really been sort of, I guess, even like sort of told or sort of pushed that we should be doing, because the evidence for this is really, really high when it comes to any type of musculoskeletal pain or sort of persistent pain. And really, I think when you understand pain and the experience of pain and how pain actually works, which has been an area I've kind of really been involved in for quite a while now, it came to reason to me to think, but why aren't we applying these principles in birth? It's kind of like the one space that, yes, that's great. We have all these pelvic health physiotherapists kind of supporting this area, but it's almost like we've forgotten pain neuroscience education, and there's huge role there. So I was starting to integrate some of this in the workshops and the care that we were providing at the womb and seeing like amazing outcomes. So then, because I teach at McMaster, it was quite easy for me to actually just supervise a group of students and run a study. So we actually studied it. We actually like studied kind of the care that we normally do at the womb, but we actually put some structure around it and studied it. And we had really a clear component of the pain neuroscience education that we integrated, but also a clear component of teaching people, this is what the best practice guidelines say. And so it's important for you to know what the research says, because you might very well find when you're in that birthing situation, your instincts in that moment actually align exactly with the best research. And you will be more likely to advocate for yourself and trust your instincts if you have that assurance that, well, this is what the global literature says is actually best. Even though this hospital setting and this practitioner is saying I should be doing something else, I know that the whole global literature base is in line with what I'm feeling instinctually right now. Right. And that's really more the purpose of it. Is we're never telling people what to do. We're just saying, like, this is what we know, but you're the expert of you. So you need to tune in, but at least you have that as a little bit of a drop. And so, that was one kind of very small feasibility study, but then it led to a much bigger study that I did in collaboration with Tracy Donegan, who is a midwife who practices out of the US, actually in Ireland. And she's the founder of Gentle Birth, which started off really as kind of like this platform of education and doula support and whatnot around physiologic birth and sort of satisfying birth, but then developed into sort of like an app. And really, like the key tenets of using this app is, yes, helping people to kind of understand sort of the best practice recommendations, helping people to understand their anatomy, helping people to understand what is optimal physiology of their hormones to help to facilitate a really optimal birth process. But then also understanding that mindfulness training has been proven to be so helpful when it comes to birth because it's training your brain. And so has hypnosis, hypno training, hypno birthing is something people have probably heard of, because it gets you into a slightly different state of consciousness. And again, it's a nervous system technique. So this app kind of has those two sort of types of techniques built into it, so people can kind of engage in daily training. So they're essentially informing themselves, but also training their brain all along the way. And then we integrated, of course, an additional pain science component to the study. We had almost 300 people go through and found huge, impressive outcomes on birth self-efficacy, reduced pain, physiologic birth, all the rest of it. So now I'm starting to work with other colleagues actually out of the UK to explore this a little bit more. So it's exciting actually that, universities that have a lot of funding are now starting to catch wind and look into this a little bit more.
Oh, wow. Do we need some work in this area? It's funny. I read one of Gaber Mate's books one time, and I
Mhm.
highlighted this part he had. I think it was in the introductions. It said three things that universally cause stress for people that they know based on research: lack of a plan,
Mhm.
loss of control, fear of
Mhm.
the unknown. And I highlighted that because I'm like, these are people preparing for birth, like all
Yep.
of these things. And I show them that, and I say, we talk about correct me if you think I'm missing something, but I always say to them, I truly think the only thing that we can control in birth is our response to pain. Like, I don't know that there's anything else we truly have control over. Is what we do with pain or the discomfort of pain. And so then I say, like, there's a lot of things that you can do to prepare to picture different things. Like, I don't know if an epidural is going to be offered to you or if a C-section is going to be offered to you, but educate yourself about those things. Understand your body. So I said we can go through these and help address like a plan, but I sometimes think of it as like a pain plan or like a response plan. So I say you don't have control over the nurse that's on, the color of the paint on the wall, which midwife or doctor shows up in a lot of situations, but learning to prepare yourself for what you're going to do in pain. And I often start with kind of an awareness of how your body works and how pain changes the way our pelvic floor responds or what we do with our body, and come up with them with strategies that they feel create more relaxation or surrender. A lot of people use the word, or let go, but they're still coming up with a plan, but one
Mhm.
that's kind of like a response plan. And so I do think that's hard for people, is to understand they have more control over the response in their body, right?
Mhm.
And learning that this is a time where we are a passenger. Like, we are our baby, or our baby's the boss in this situation, and we're trying to help the baby come out. And so I think if they reframe their plan in that way, but like you said, all this preparation through understanding how pain works and understanding how the brain and the nervous system works still gives them that element of control.
Yeah, absolutely. And I would say the same thing, like really helping people to understand the thing that you can probably control the most is certain aspects of your physiology,
Yeah.
which will dictate output. And pain, of course, is an output. So even other things, like you're quite right, you can't control what nurse is on. You can't even control now, even if you have a midwifery group that you've been working at.
Mhm.
The context in Ontario is these groups are kind of getting bigger and bigger and bigger. So what used to be this really amazing, you met your midwife and you knew for sure that was going to be the person with you on the day you were birthing your beautiful baby. More and more, I have clients saying, actually, the two midwives with me that day were like midwives like I hadn't even met. So
Mhm.
this is really a reality of our healthcare system, right? So yes, you can't control that, but you hopefully, if you've had conversations all along the way, which is why if you're educated and you're advocating for yourself around, you want the lights really, really dim because you know melatonin goes hand in hand with helping oxytocin to work better. You want, well, yes, like those are like that's physiology. So as long as you have some planning, you can control physiology. There's certain
Mhm.
things you can't control,
Mhm.
but you can control some of those things. You can certainly control your brain structure through doing mindfulness training to have your brain in a structure that it's much less likely to interpret benign things as threatening, right? So I would agree. There are a lot of sort of internal things that can be controlled that I just don't think people know about. Or I think people understand, yeah, I know that that's helpful, but I think they think it's only like a little bit helpful. I
Mhm.
don't think they realize actually how powerful and transformative mindfulness programs are for this. When you're pregnant, your brain is totally plastic, it's completely
Mhm.
changing. So it is actually the most amenable to these types of protocols. So like these protocols are hugely effective, especially in that time because of how plastic the brain is. And I just don't think a lot of people know about it. I don't even think a lot of our colleagues in pelvic health PT, Mel, even understand the physiology very well. I still think a lot of our colleagues are very much stuck in the structure. One of the
Mhm.
reasons why I actually don't love the term pelvic floor physiotherapist,
Mhm.
I like pelvic health physiotherapist
Totally.
because I'm really moving away from the structure. The structure is a dumping grounds for everything else, and it's important, but it's like a little this much important,
I'm
right?
so guilty of using that term still because I feel like when I say pelvic health, because I would consider myself a pelvic health physio, but then people don't know what that means. So I feel like I get
Mm,
stuck using the same terminology to like meet people where they're at all the time. But I totally agree with you. I catch myself saying it all the time.
for sure. But that goes hand in hand too, honestly, with like even this whole terminology around Kegels.
Yeah.
I get it. People keep using that because it's kind of what the public understands. It's
Yeah.
what the Google search terms are.
Hmm.
And I get that because when we are trying to prove help seeking, you want to make sure you're using
Hmm.
terminology.
Hmm.
Like, so I get that. But that then at the same point, it's like, well, how are we really going to get the message across that that's not really where it's at?
Hmm.
It's hard. It's like a tricky thing. But yes, I do think you're quite right. There is so much about the physiology, including pain physiology, which is a lot of cognitions and fears and how you interpret things. Um, that we can control, or we can at least build up buffering capacity and resilience. So when the things we can't control come on, we got it because we have enough capacity built up that we've got it. It's not going to break us down, right?
Hmm. And that's something that I try to explain to people when they come in is when they're wanting to prepare, like they're here again because they want to prepare for birth. I kind of make a parallel to preparing for something like a knee surgery. And I'll say, like, thinking about kind of like maximizing range of motion and strength going into a knee surgery. Like, a lot of people want to go in feeling like they're prepared physically that way. So I'll say, I think of the pelvic floor that way too. Like, I want you to understand how you have range of motion and that two ends of the spectrum are very important. Like, tension's important, relaxing's important, and start with almost like the physical preparation. But then I also say what a lot of people don't know though, like the difference between a nurse knee surgery and a birth is that you're knocked out for your knee surgery. You're not an
Mm-hmm.
active participant, whereas in your birth you are an active participant. And then after I've shown them the anatomy and they understand the pelvic floor a little bit more, and I'll say, what does pain do to our muscles? And then you can see they're like,
Mm-hmm.
oh my gosh, it creates tension. I don't want tension, you know? And so that's where I find I can kind of add, like, I don't know that people don't learn much about working with pain, or people don't learn that they have ways that they can work with pain to create the desired response. And I really don't think there's other practitioners, like, I don't think their midwives are going over that. Well, I can speak to like in town here, like they're not going over that. Um, like the nurses don't have time to go over that when you come in. I really don't think most of the birth classes are doing that with them, like you said. And so I
For
find
sure.
sometimes I really have to kind of put that plug in for us as physios is like, I know you didn't come here thinking we would help prepare you for birth, but let me tell you some of the things that we can do. I think that's big for us. Yeah.
Totally. And I would say that too about pain, Mel. I'm glad you brought that up. It's that concept. And to me, again, this is sort of a little bit of a derivative of pain neuroscience education, which like I feel like this is where PTs should be championing the space. But it's like pain has a purpose. Pain is actually there to protect us. And in the case of birth, we have to think, okay, so what is the purpose of pain? And the purpose of pain is to say, Mama, pay attention, get somewhere safe. Like I'm coming.
Mhm.
And I think we're so conditioned to think of something of pain and how are we going to minimize the pain and stop the pain and stump the pain and stuff the pain. And
Mhm.
instead of getting curious about the pain, and
Mhm.
that's a key tenet of pain neuroscience education, particularly when pain is persistent, because oftentimes it's an output that's happening because something else in our life or in our physiology is not quite right. And you're continuing to have pain because it's trying to alert you of that. It's trying to help you to like figure that out so you can get back into homeostasis. And in this case, it's to say like, baby saying, Mom, I'm coming. So I think to help people understand, look, pain, even though it's going to be unpleasant, it has a purpose. So even if you can start seeing it from that perspective and getting curious about it, excited you're going to meet your baby and
Mhm.
kind of know, yes, you have lots of different things you can do to deal with the pain unpleasantness. And the pain unpleasantness is a specific dimension of pain that really the data is so clear that it's our non-pharmacological techniques that actually target that aspect of pain. So those mamas who you talk to who say, yeah, no, I didn't have any pharmacological pain care, but I had my doula and my this, and I was doing the things, and I was in and out of the bath, and I was doing my things. And yes, of course, at times it was really uncomfortable, but like I was okay. And then you can have on the flip side lots of qualitative data showing that mamas who had an epidural, who sort of that sensory component of pain was cut, but they were given an epidural and then left on their own, that they actually were quite traumatized by the whole experience, right? So, like, pain and suffering are two different things. Like, the sensory aspect of pain and pain unpleasantness are two different things. So, our clinical practice guidelines say really, really clearly, even if someone is having pharmacologic pain care to kind of address that sort of sensory nociceptive aspect of the care, we know that that still doesn't do a lot for the person feeling like supportive and the pain unpleasantness or like the sensory unpleasantness. So we need all our non-pharmacological kind of supportive tools in place, and so that's something else I think a lot of our clients don't realize, even when they're saying, yeah, well, I know I want an epidural and whatnot. And that's great because if that is going to make someone feel safer and kind of more in control, great. We have that in our country, great. But the
Mhm.
guidelines are really clear that that's not going to sort everything,
Mhm.
right? So it's just, I think, yeah, I think people deserve to be able to make informed decisions for themselves. And I guess at the end of the day, still in the birth space, people aren't making informed decisions for themselves because they're going into it not with all the information. And when they're in that, you know, state of the whole birth bit, that really isn't sort of the time to kind of be given new
Mhm.
information,
Mhm.
right? So at that time, things are just so overwhelming that it's understandable that people will just kind of turn things over to their care provider team. And that's really understandable. And in some cases, I think that that works out well, but there's a lot of cases that doesn't work out well. And it's the times it doesn't work out well, and it's predictable that it doesn't work out well with everything we know. I think that's really what, people like you and I, Mel, are kind of here to try to help with. Like, how can we try to help this? How can we try to help people sort of get through this whole perinatal care stage as optimally as we can based on what that person wants?
Well, and that's what I was gonna say is I think those of us that use these strategies, like that you can feel that difference with some of those moms that come out, and you can just feel through their email or whatever they're beaming with pride that like I did that or I really worked with my body, and you can just feel that difference. It's
Mhm.
and that's one thing that whenever someone like a labor and delivery nurse comes in as a client, I always ask them like, why are you here? Because you do this all the time. So pinpoint for me what you feel's missing. Do you know what I mean? Why have you come to see me? And they always say something like this. We watch women have babies all the time. Some of them are fighting it the whole time. And some of them have done something to work with it. They're working with their body. And I
Mhm.
always say that's never one thing. There's not there. I have no magic to give you. I do not have a magic pill to give you for that. But at the end of the day, they've implemented some of the things that we've just talked about. And that's kind of the last little thing I want to kind of like tie this all up is like implementation. So
Mhm.
I think mostly we've talked about like personal implementation, like how we
Mhm.
one-on-one work with
Mhm.
people to implement this. And some of them, we're saying that we notice a difference when this is
Mhm.
implemented on a one-on-one basis. I am starting to feel a little frustrated with the one-on-one implementation, I'll be honest. And I think some
Mhm.
of us have I've tried to be creative with different online programs or like reasons I put out this podcast, but I just feel like it's like too downstream in so many ways. Like I'm not saying
Mhm.
it's not effective. I can just tell that I'm like, this needs to come from higher up. And I'm interested your thoughts, like especially, I know you implement this one-on-one, but what else, like what other creative ways have you tried to help this gap not exist?
Mhm. So one of the things, so there's a couple of things. So, and it's a great question. It's like even when I go back to like my roots in primary healthcare, because that's what my PhD research and everything was in. So that's ultimately sort of always the position I kind of come back to, right? Um, it very much is we sort of need every relevant healthcare provider kind of like saying the same thing, enacting the same thing. We can't just have it kind of dumped to the pelvic PTs who are kind of doing this on a one-to-one basis, as you said. Like that's never really going to move the needle enough. So there's a couple of things. So one is sort of this idea of group programming, which again is a very big like primary healthcare concept. And so actually that first study that I talked about that I did, it was a workshop. It was a group. It was a workshop of 12 couples. So we had that good of outcomes with a workshop, a 90-minute workshop. Couples attended. We did all our outcome measures before the workshop. We did them again after the workshop to see if there was a change in perspective. And then we interacted with these people after they birthed their babies to kind of see the outcomes, right? So we ran 2 of these workshops. So we had 12 couples and showed huge effects. So you're not seeing anyone one-to-one, you're not assessing them individually, none of that. And that is how powerful those effects were. So do not underestimate the impact of these types of workshops when they are built on evidence-based principles. The other thing I would say is that second study, of course, is an app. It's called the Gentle Birth app. That is the app we studied. Now, the app doesn't have the pain neuroscience education course because that was a separate online kind of component. But again, the Gentle Birth app is now well vetted in science, and it's something that doesn't require this one-to-one care. It very much is empowering the client to kind of do their own self-management, right? So that's kind of like another thought. The third thing that we've done at the womb is we've actually developed a curriculum for the local midwives. So I think we've ran this little course, I think probably for like a dozen different midwifery groups kind of in our area. We block off 2 hours of time, we deliver it through Zoom, but it's really us kind of going through not content that's very different from that study we did in the context of the workshop, but we're actually giving that to the midwives and as a way to try to kind of triangulate and kind of flow down care that way. So, I mean, those are some of the things that jump off the top of my head for sure. But I would say, I mean, when it comes to something like the popularity of prenatal yoga, right? There's a couple of things within that sort of discipline of activity, if you want to call it that we have so much substantiation for birth. I mean, we have so much data to show that that's helpful for any type of lumbopelvic pain. We know how powerful like the mindfulness component is for mamas, for fear, stress, birth, depression, anxiety, pain, like all of it. And there's the shavasana at the end with the mindfulness component. So, I mean, even I would say a little bit of like a spin-off is helping people to understand, like, doing your prenatal yoga class isn't just kind of this trendy, cute thing. It has a lot of substantiation. So clients who come in to see me and they're saying, hey, so now I'm going to be 34 weeks and, I really want to get into like the perineal massage, the perineal stretching. And I'm saying, that's great. That's a tool that can be helpful. The research profile for it isn't great, but it is another tool. And if it's something that will make you feel more empowered, that's great. But are you getting your daily walks in? Are you getting your prenatal yoga in? Are you getting your mindfulness? Are you getting the things that have way better evidence that are going to move the needle way more? Because if you don't even have time for those things, and a lot of the mamas I see don't have time for those things. And in their mind, they're thinking like, well, if I just like do the perineal stretching, then I've stretched my perineum and then I'm okay. And it's like, no, like that really won't be a constructive use of your time if you haven't even gotten your walking in. You haven't even got your time in nature in. You haven't even got, right? So I think even thinking about just some of those basic things like getting out for your walks, getting into your prenatal yoga classes, like those things that are kind of more in groups and are more self-management, those interventions that are like the low-hanging fruit that are so well substantiated. I think a lot of our colleagues in perinatal care, like all relevant disciplines, don't even sort of explain how effective those basic things are.
Mm-hmm. Yeah, I think like you said, there's ways like beyond one-on-one. Like I just think about be creative and create different workshops in your community. And I think too, like
100%.
I can't help but think that reaching out to some of the groups that already have the kind of birth prep classes and just, meet with them. Is there, a way you could add to it? I don't know. I mean, I think it can be in so many ways it can be different, right? I think that the
Especially with
implementation's hard.
the pain neuroscience education piece for sure,
Mhm.
Mel, because really that's sort of how our workshop started in the first place. I actually jumped in with that component into a workshop called Birth Without Fear that our doulas already ran.
Mhm.
But one of the things that they didn't do well was really explain the pain science bit,
Totally.
right? They talked a little bit about the fear tension cycle and they sort of danced around it. They talked a little bit about some of the comfort measures that were used by doulas, and they were really referring to the gate control mechanism, but they weren't using that language. They weren't differentiating that from the Dimnick mechanism. They weren't differentiating that from, so it just wasn't as sophisticated. And so it wasn't as clear, and it was actually less empowering. So, kind of when we came in to really delineate it, actually based on the SOGC guidelines, because they map all those different mechanisms out, um, we found like our outcomes were so much better. So that's a great suggestion. It's essentially what we did, and I failed to say it. But yes, collaborate.
Mhm.
Collaborate. You don't need to reinvent the wheel.
Don't
Like things
reinvent the
that
wheel.
already exist, but are missing key components. Maybe they're not translating the recommendations from the guidelines. Maybe they don't have a pain neuroscience education bit. And like those two pieces in and of themselves will really kind of move the needle a bit more. So I love that you brought that up.
Mhm. Anything else? I mean, I'm mindful of your time here, but anything else that you feel like I didn't ask you or you think's relevant for this conversation? I mean, we could talk about this for like days, but yeah, anything you feel like I missed?
The only other thing, and I think we kind of talked about it, I just think like I'll punctuate it one more time, is it really is in a spirit of empowerment. Like, really, whatever you can do to either work with other care providers, kind of group programming, or in your own one-to-one programming, to kind of really think of empowering that person, on the other end. That's also so important. And so we really do want to make sure that in our interactions with clients, they actually aren't thinking that we somehow do this magical release of their pelvic floor every time they come in and they require something external to them to kind of get the result they need, because that's a bit of a trend I've seen in clients, particularly clients who've come seen me after they've worked with other pelvic PTs. So I think just that concept of empowering that person to understand their body, to trust their body,
Mhm.
to actually like really believe in the competence of their body. And when you're sensing that that isn't there, then you need to work on that. And that is more our psychologically informed skills, not our tissue-based skills that are going to help people to get over that hump. But if people have that self-doubt in the competence of their body, and they haven't been able to get past that, that 100% will show up during their birth, because, that's when there's a whole flood of things, right? And the doubt's really going to pop itself up. So I really think that concept of empowerment developed that competence. And that's why when we have our mamas exercising and moving pain-free, and as they get further on in their pregnancy, they're feeling actually stronger and better. Those are all things that really make them feel competent in their body when it comes to the birth, right? So we need to kind of be helping even our clients with those types of things, and that will trickle over to
And don't you
how they
find,
are in their birth.
sorry to interrupt there, but don't you find that once they kind of understand this concept and they learn that they're just trying to figure out themselves and how, like, what things make them tick or what things make them relax, that all of a sudden, all those messages from social media start to them. Like I always say, picture that everything you hear on social media is just an idea. Like that's just someone, they're not giving you an ingredient in the recipe. Like you can start to then look at that video or whatever you're seeing and like, will that help me? No, that doesn't. Okay,
Mhm,
move on. I think it helps them. I think what one big takeaway I hope people get is that we're not listing more things you need to do, but I
mhm.
think thinking about it this way or preparing yourself this way makes you realize you almost have less to do. Right? Or
Totally,
like there's less like specific items that you need to do to prepare, but it's like a big umbrella
totally,
picture, right? Or yeah.
totally, totally.
Yeah.
It's almost like a slightly different approach.
Yeah.
And actually, it should make things simpler,
Yes, and
right?
make more sense. And you can just feel the weight come off their shoulders. I feel like when those dots click, they're like, oh my gosh, thank you.
Totally,
This makes me feel so much more prepared. I'm like, that's great. That's what I was hoping for.
totally. I agree with you 100%.
So, I'll make sure that I link, where people can find you, and you and I'll make sure that I get from you anything that I'm allowed to share. Like if there's
Yep. Like the
any
papers and things.
resources or the papers that I'm allowed to share, in the
Yep.
show notes, I'll make sure that that's all there. Um,
Perfect.
but again, thank you, thank you, thank you in so many different ways for all you're doing. And yeah, if I can ever be of help in any of this, then you know where to find me.